Okay. My name is Kevin Cosby, and I am the pastor here at St. Stephen Church. Okay. Hello, my name is Kevin Cosby, and I'd like to welcome you to St. Stephen Baptist Church and all who will be participating on a very critical topic, and that is the topic of health. There are so many health disparities, especially in low-income, low-opportunity communities that do not have the support systems, and oftentimes because of the pollutants in the air, the lack of access to health care, the invisibility of urban communities, especially communities of color, and in particular, black communities, the disparities in health is not always the result of your genetic code, but it is the result of your zip code. You can almost track the health disparities based on the level of poverty, not just economic poverty, but social poverty and health poverty that these communities are experiencing. There are basically two types of policies that are important if we're going to close the gap in health disparities. One is personal policy. Personal policy has to do with the choices that I make and the lifestyle that I choose to live. But in addition to personal policy is public policy, and they are interrelated because oftentimes you don't have many choices, and that's the result of public policy. And so we're here to talk about health and cancer, lung cancer, and it's appropriate that it would take place in the church. The church is the mother of our institutions. It is the hub, or should be the hub, of activity for people in our community, and it's the one institution that we own and we control. And if you're a follower of Jesus Christ, you know that one of the missions of Jesus Christ was to bring health to people. In fact, when Jesus talked about salvation, in fact, overwhelmingly, when the Bible talks about salvation, it's not talking about something otherworldly. It's not talking about some pie in the sky when you die. But health is always, or salvation, wholeness, is always something sound on the ground while you're still around. I want to read a scripture that I think is to you about health. That is one of my favorite stories. It's the story of Hezekiah. And Hezekiah was a righteous king, but Hezekiah became sick. And he prayed to God. Let me just read something, and then I'm going to skip down to verse 21. It says, in those days, Hezekiah became sick and was near death. Isaiah, the man of God, who's a prophet, Isaiah, the man of God, the son of Amos, came to him, King Hezekiah, and said, the Lord says, make those of your house ready, for you will die and not live. So Hezekiah is terminal. Then Hezekiah turned his face to the wall and prayed to the Lord. And he's going to pray to the Lord and ask the Lord to heal him. And God sends Isaiah back to Hezekiah and says, I've heard your prayer, and I'm going to add to your life 15 additional years. But then he said this, because we often talk about, well, he prayed and God gave him 15 years. But listen to what verse 21 says. And this is Isaiah 38 and verse 21. It says, now Isaiah had said, let them take a cake of figs, put it on the sore, that he may get well. So some ointment that they made with figs or medicine they put on whatever sore Hezekiah had, and it was the medicine that healed Hezekiah. Now, was it prayer or was it medicine? Was it him going to God in a spiritual way, or was it him really taking serious what science, the science of the day, had to provide for him? Well, it was both. It was both the medicine and it was both prayer. Unfortunately, many Christians just focus on the prayer piece. But according to Isaiah 38:21, he got healed once he put this medicine or this ointment on the sore. So we're in church and it's a place of prayer. Jesus said, my house shall be called a house of prayer for all people. But it's not only a place of prayer, it's a place also where we find about medicine. We find about what the science has to say about health care, what the science has to say about how we can live healthy lives. So I'd like to welcome you to this forum. There'll be a lot of great information that can be a great source of blessing to you, because health is wealth. And God wants to add, just like he did for Hezekiah, 15 more years to your life. And if you don't have the right health regimen, then instead of adding 15 years to your life, 15 years of your life can be subtracted. And that is why this is so important. It's interesting that in the middle of the word life is the word if. L-I-F-E. And that's because life is so iffy. And if we can do those things and practice good health care, both in a public policy and a private policy, then we can not only live a great life, but we can live a high quality of life. So I'd like to welcome you to this forum.
Good morning, everybody. Thank you all for coming out on this sunny, chilly day. It means that you took health as your, prioritize your health this morning, and we want to thank you for coming out. And you either want to come and teach and come and learn. So you always want to be on one side of that pendulum to teach or learn. So thank you all, and thank you all for online. I am Faith Danzy, and I'm with Hill Collaborative, and I am the project lead for this. If you have lungs, you can get lung cancer. And we want to thank St. Stephen's and Dr. Crosby for allowing us to be here today, and we're just grateful to have this space to bring this critical information to you. We want to thank AMGEN, our sponsors, for allowing us to come out and give this to the community, and we now want to thank Dr. Tuckson. He's going to be our moderator for today, and today we'll be talking about patient navigation, targeted treatment, public policy, and clinical trials.
Thank you very much, Faith. And thank you very much, Dr. Cosby. I tell you, the question often is it faith or science? And I think you definitively said the answer is yes, it is. It is both. There is no dichotomy. One without the other doesn't stand. So thank you very much for that. I found that quite interesting. Brought some interesting thoughts for me. I'd like to welcome our panel members up. As I read you off, if you could come on up and join us up here. First panel member is Mr. Lyndon Pryor. Mr. Pryor is the interim president and CEO of the Louisville Urban League. He previously was the chief engagement officer. I don't know if he really knows how much engagement he has gotten himself into right now, but I'm sure that he has. But I know as you strategize with members in the community and stakeholders, we look forward to you doing great work. Next, we have Ms. Michelle Ottersband. She's a clinical nurse coordinator. clinical nurse navigator, and she has a long history in prevention and early detection and management with lung cancer. She has a long history going back with several iterations of healthcare companies here in Jefferson County, and it's always good to see you again. Finally, for right now, we have Ms. Yolanda Hildenbrand. She is an oncology social worker at the Norton Cancer Institute. She's also a licensed clinical social worker, which means that she not only helps patients in terms of navigating through the maze of the complex of healthcare system, but she also can help as far as diagnosing, treating, and providing guidance in developing strategies for patients as they cope with the problems which they go through. What we're going to be talking about today is patient navigation, care, and support. The primary interest is, what goes on as far as early detection and screening, smoking cessation services, but what does it look like from that patient's perspective? We will have another panel member, Ms. Virginia Bradford. She's running a little bit behind, but when she arrives, she'll be joining us also, and I'll introduce her when she arrives. Let's first start off with you, Ms. Hildenbrand. When we think about the complexity of the healthcare system, I must admit, as a clinician myself, it can be a maze and somewhat daunting. What does that look like to the patient who has now said, oh, by the way, not only do you have to go through this maze, but you have a cancer?
First, thank you for having me. I truly appreciate the opportunity to talk about something that I truly feel like I'm in a blessed position to talk about cancer and to help as many people. As far as your question, patients vary when they come in and they find out that they have a cancer diagnosis. So no one's diagnosis is quite the same. My job is to help support them in that diagnosis. And that could be mental health, which is part of my job, and also community resources.
So then let me ask Ms. Ottersman, and in fact, I'm going to say your last name now, but subsequently I'm going to use your first name, and I hope you all will forgive me for the familiarity. But Ms. Ottersman, when we talk about early detection, the steps that we have to go through, how do you capture that patient, and how do we not lose that patient as they go through that process?
Well, thank you again for having me here. In terms of capturing, it all begins with outreach into the community, building that relationship with the primary care physicians, and obtaining trust not only with the community that you're serving and trying to bring in, but you also have to build that trust with that primary care provider. The importance of lung cancer screening and early detection is to make sure that healthcare systems have a structured process in place to capture these people to make it easier to get in. So you have a dedicated telephone number, the person can come in. If you don't have a primary care, we have go-to screening centers of excellence in the city of Louisville and the state of Kentucky. With Norton, we have many of them, and we can help get you in. If you cannot get in, you can contact the go-to for lung cancer. They can help find you one. But we capture those, and then you will interact with a navigator who will help make sure that you have a primary care physician, insurance, or financial assistance to help cover any subsequent follow-up. We then will schedule your scan, go over the process of what it is. So with lung cancer screening, it's not a one-time CT. It's a series of low-dose CTs that we evaluate over time to keep an eye on the little spots on our lungs. And so we just keep an eye on those. And then we have navigators that will remind you and schedule your next follow-up to make sure that the quality of care, of the highest quality of care, and also make sure if there's anything abnormal on that finding, there is not a delay in treatment. And if you have any questions anywhere in the country, if you cannot find that navigator or that structure program, We have resources. The go-to for lung cancer, longevity, we all have those if you can't find that healthcare system. Norton is excellent. So for the city of Louisville, you have Norton's, you have University of Louisville, you have Baptist, and so we all have navigators. But if you can't find that, contact them. They will connect you directly to that navigator. And if you're having symptoms, you can always call that navigator, and we can get you expedited in to see a physician. But that navigator is going to guide you throughout the process, not only for that first scan, but throughout the years to keep you going, coming in to get your primary care wellness visit with your primary care physician. Also, to make sure you get your low-dose CT as a preventive wellness screening, just to keep an eye on those spots. But the navigator is always available to you at no additional cost. So we're here to serve you as the community to make sure you get in for follow-up appropriately and tracked.
Thank you. Thank you very much. Mr. Pryor, with the Louisville Urban League, you are at the intersection of health and wealth. So when a lot of times when patients are looking at things, do you help people prioritize? How do you help someone when they're in this position? And tell me what that might look like as you're trying to help them work through that part of the maze.
Thank you. And I'll say, in addition to the hat I'm wearing with the Urban League, I'm also a board member for Gilda's Club of Kentuckiana, which is a cancer support community, cancer care community here locally, and does a lot of work in terms of supporting families and patients who are dealing with various types of cancers. To your question, you're absolutely right. We see folks who are dealing with all sorts of obstacles and barriers, and those things can oftentimes become an impediment to them taking care of their health. I can't tell you the number of times that we have had individuals who come in and sit with our community health workers because, they are there because, I need a job, or I am trying to get my finances together, or I am dealing with some other issue or trauma in my life. And we go through a series of questions with them through an assessment. And we ask basic questions about, when do you have a primary care physician? When was the last time that you've been to your doctor? And oftentimes that is something that is far down on the rung because they have prioritized these other issues in their life. And so sometimes we will have cases where a client is in pain or dealing with some sort of medical issue, and we will ask, have you been to the doctor? Well, no, because I am worried about X, Y, and Z. And so we do sit with them to talk about, all right, let's talk about how we deal with whatever obstacle or issue is right there in front of your face, but then let's bump up your health in terms of priorities. How do we get you in front of a doctor? And it is that process of negotiating and coming to common agreements so that people can begin to move their health up the priority scale for them so that they can get, into a doctor and see, and hopefully if it is something serious, that they're getting that early detection or whatever other services they may need from their physician.
Boy, thank you. That's a wonderful, wonderful service that you provide. So, Yolanda, taking that from what Lyndon just talked about, Michelle touched upon it briefly also. As you know, in my experience also, you say the word cancer to somebody, but in particular lung cancer, when we look at the dismal survival statistics that have previously been out there, how do you help that patient now handle the stress of that diagnosis? What are the strategies that you give them so that they may address all the other things that they have to do?
As far as a newly diagnosed cancer patient that may come in, and the first thing I'd like to do is make sure that they're aware of the type of cancer,
okay,
the staging of their cancer. That's the first thing. Now, I'm the social worker, so I don't get into the realms of it, but I get into making sure they know, because a lot of times the knowledge is not there as related to the cancer. So sometimes it's kind of diminished by the particular patient. But what I do after they know for sure what they have, what's going on, I come up with a plan with the patients. So my first thing is to make sure that they have insurance. That's the first thing I ask. If they don't, and what I do initially when I meet with a patient is an assessment. So the first thing is, do you have insurance? My second thing is, do you have support? Okay? Because support is extremely important in going through that, I want to call it that journey. The third thing with a particular patient is I talk to them about cancer groups, because groups are also important because they're also a form of support. So we go through those things, and if they do not have insurance, or if they're having some type of financial difficulties, because a lot of our patients may not work, may be on fixed income. So what I like to do is give them the resources. So it may be me helping apply for insurance for a patient, or giving them the resources to apply themselves, which is something as a social worker that we like to do, is empower the patients to do for themselves. Now, there are those patients that are not able to, so I do step in and kind of guide them, or I try to find a family member to guide them, or I'll even find someone out in the community that can guide them or help them. And I talk to them about the things that Norton Healthcare has as far as resources, because a lot of times when someone hears that they have cancer, if they don't have insurance and they don't have the financial means, they check out.
Yeah.
So what I like to do is say, here, this is what we have, this is what we can do. And then that way, I kind of get them on board so we can go ahead and what I call it, get through this.
We're going to come back to that term, check out, in just a minute. Our fourth panel member is able to join us now, and she is Ms. Virginia Bradford. Ms. Bradford is a cancer outreach coordinator with the Kentucky Cancer Program, and she has a long history in working in the community as a health educator, empowering the African American community regarding cancer. Now, before you get too settled down, I got to ask you, when we talk about awareness about cancer, and in particular lung cancer, do you find it different in the African American community versus majority or other communities around? And thank you for being with us, Virginia.
Thank you, Doc.
There you are.
Thank you, Dr. Tuxson. Yes, in answer to your question, I think there is a difference. Can everyone hear me now? Thank you. The stigmas that are associated with smoking in the years now versus before, I think that they feel, I hear people say, well, I have to go outside and way away from the building. I can't, I'm criticized for even being still smoking, but that's what I want to do.
Before we go further, if there's anyone here who has a question, if you just raise your hand, I'll be sure and call upon you. And if I haven't gotten you right away, keep the hand up. I promise you I will get to you. But let's take that another thing, though. So often, especially about lung cancer, and I'm curious about what the panel will tell us, we say, well, you're a cigarette smoker. You brought this on yourself. How do we address that issue? And is that even something that we should be talking about with the patient?
I think that with any of the risk factors that can cause cancer or other chronic diseases, as we're talking about being obese, or we're talking about not just smoking, but just being sediment, just not exercising. I think that all of those things, we really have to look at how we're talking with that person and finding out, well, do you find yourself eating more, or do you find yourself, why do you smoke? Why do you drink? Mm-hmm. So I think it's our approach when we are speaking with that person and helping them to make better choices. Mm-hmm. So we also can offer a solution. Well, we've got some things that can help you. if you're really, truly interested in stopping smoking, if you're really, truly wanting to, it's not even about losing weight, but having a healthier body.
Yolanda, what about that? Is there a certain psychological impediment that patients may have entering and say, well, I'm going to go in here and I know they're going to tell me this is my burden because I did this. Is that, how does that interact in terms of the interplay between the patient and the providers in terms of their following through on things?
Okay, there are many patients that will come in and say, I've been smoking for 30 years. So one, why should I stop now? I already have cancer. And two, it's just the education again on how to stop. A lot of times, I want to say as far as the patient going in and the interplay with the providers, sometimes the patients don't feel comfortable with the providers. So that's how I get them. What I like to say to patients is I don't say, yes, you've been smoking for 30 years. This is your outcome. Instead, what I like to say is, I get it. It's become a habit. So now we have to learn a new behavior. So that new behavior is to decrease smoking. So I don't say to somebody, okay, stop smoking. You got cancer. We're about to do treatment. Because realistically, they're not going to be able to stop, right? So instead, what I'll do, and it's part of the nurse navigator's role also, is they talk to them about smoking cessation, okay? I talk to them about that, but again, I talk to them about behavior modification. So what I'll say, how often do you smoke? They'll say, I smoke a pack a day. Let's get it down to half a pack a day, and I'll do that for a couple of weeks because realistically, you're not going to be able to just stop smoking. So I like to offer reality-based alternatives to patients because when you offer reality-based alternatives and meet the patient where they are, the outcomes are usually better.
And more acceptable. They accept it better that way because they don't feel that they're being ostracized or told what to do. Some people feel I'm grown and I do what I want to do, but now it's time for us to look at doing it differently.
Michelle, let me ask you a question then. We know that there's primary exposure, and that's the person who's smoking, but there's also second hand, which is the family members who are around where the smoke, and third hand, where the smoke is on the clothing or even on the furniture and things where others are exposed. What do you tell the patient, or more importantly, what do you tell the family members about their now increased risk because having a smoker in the house for them, what are some of the things you kind of clue them in that they have to watch out for and or shouldn't be doing?
Yeah, when as a nurse navigator, when you're not only there serving the person who's you're taking care of, but you're also serving their family members. And so if you've been exposed to whether primary, secondary, or third-hand smoke exposure, it's what can we do with what we have to reduce further risk. So it's about the holistic improving your starting where we are to improve the overall health. So with secondhand smoke, some people can avoid it, some people cannot. But what can we do to reduce those risks over? And so if you live with someone who smokes, what can we do to help facilitate the quitting process while being supportive to that person? And so there's ways, do we smoke outside or like if you're working in a bar, or someplace where there's smoke, you have to pay the bills, right? So there's policy issues there that, but we could say that. But what can we because there's some stuff. Sorry, that's a really good question. It's just
Thank you.
try to. There's things that have to be changed at policy levels, but what can we do with ourselves is, sometimes, if you can wear a mask, just what can you do there? So if you have to work there, but but focus on the other risk factors, we have as well, which is, eating right, exercise, seeing your primary care physician. So there's, and then if people are able, if you're working in a place where there's high amount of smoke, if you're able to find a new job, that would be great. But sometimes it's not possible. So you have to deal with what you have. Or whether if you work in an iron plant, they pay pretty good money. So, you need that income. So what can we do there? So is there things that you can do working with your employer to help protect yourself under the EPA? But there's some things that you can, but just whether it's just just washing, like when you come home, just wash your clothes, before you come in the house, and so you don't expose the family. There's just things that you just have to, what can we do to reduce the risk? But that was a really good question. I don't think I've answered it.
Well, no, you did. And you brought up an interesting point, because Lyndon, we know that the coal worker who comes home tries to remove and mitigate exposure of coal dust to his family by changing the clothes, washing. The person who's living across the street from a factory that is spewing out toxic or pollutants, they can't wash this away per se. So how do you, in terms of your interplay, because with the Urban League, you're not only dealing with people, but you're dealing with policymakers and industry. So how do we discuss to say, hey, wait a minute, as Reverend Cosby said in his remarks, it's not just your genetic code, but it's your zip code. So what do we do to make those zip codes that are high risk better? What kind of argument do you bring to say the health of the community is just as important as the wealth of the community, and how do we get there?
We fight, and we vote, and we raise our voices. This conversation is really pertinent, particularly around this topic, because right now, for those of you who don't know, the mayor has convened city leaders, corporations, and whatnot to talk about how do we grow Louisville. And so this whole conversation around economic development for the city. It's a big deal. And in one of those presentations, one of the things that talked about is one of the assets that Louisville has is its water. And you all have probably heard this a million times, that Louisville has some of the best water in the nation. And quite frankly, we don't use very much of it. Almost less than 1% of the water that we have access to, we don't utilize. We sit right here on the river as well. And that's an attractive thing for manufacturers and people coming to Louisville and bringing business. And so when I've been in these spaces, the point that I've raised is that's all well and good, right? Maybe that is an attractive thing for the city. But what does that mean environmentally? So maybe that company is not going to pollute the water, but if they're going to pollute the air, that is just as bad. If they are going to be in situations where they are conducting businesses in neighborhoods, which, as we know here in the west end of Louisville, our neighborhoods line up right around the river. There are several plants that are already there. And so if they're going to be doing things that are harmful to the community, then what is the responsibility of the city, of other corporations, and others to make sure that we are mitigating the risk of who we're bringing in? And for those who are already here, what are we doing to curtail the negative impact and harm that they have? But that is certainly on our policymakers, our council members, the mayor, and others. But it's also on us. We have to raise our voices. We have to show up in spaces to tell people that this is not okay, that these are things that we're not going to be okay with. And the data is there. We know the prevalence of things like asthma, like cancer, COPD, lots of different things in our communities. And we know disproportionately where those things reside. And we can often map them right along the areas where there are these plants and manufacturers. And so we have to do better about using that data to really advocate for ourselves and ensure that those things cease and don't happen again in the future.
But there's got to be a sense of verboten, depression, extreme frustration on the part of the patient who says, I have an illness which is being made worse by where I live. What do we tell that person? I'll ask you, and then I'll ask Yolanda.
There aren't good answers, to be very honest. I mean, we've seen in certain communities, in other states and in other municipalities, class action lawsuits that have been taken, in which they have sued companies because of the health and harm that those companies have perpetrated on those communities. And, you know, we've certainly seen people take on, you know, very aggressive protesting and those types of actions to be able to stop those types of things. But there really aren't great answers, and that is the hard part about it, right? But again, there's always strength and powers in numbers, and that's why, you know, doing conversations, having conversations like this in institutions like the church become important, because there is a collective here to where even if it is not your personal experience, if you aren't the one who is directly infected, there's somebody else in these pews who is. There's somebody else, you know, in your family who is. And we have to begin to galvanize together and to really wrap our arms around one another to lift our voices up collectively, because it does actually work. And again, there are instances in which corporations and manufacturing plants have been shut down. They've moved. They've changed the way in which they do things to better improve the health of the particular communities that they sit in. The action does work. We just have to organize and move.
So, Yolanda, if you would address that also, how does the patient, what do you tell that patient when they come into you and they know they go back home every day and they look across and they see the vector or they smell the air? How do they deal with that?
Well, I'm going to agree with what my co-panelist Lynn said, but I'm going to take the route nobody likes, and I'm going to call it the reality route. Mm-hmm. So when I have a patient that comes in and they may live, you know, where the air is bad, at this particular time and place when I'm with that patient, I can't change that patient's environment. So what I do is come up with how I can make that environment better for the moment, how I can make that environment better for the patient while they're in treatment. And I'm going to just, you know, kind of piggyback off of what Michelle said. One thing is change up a little bit of what's going on, right? So we have the lung cancer patient. They're smoking. However, there are some lung cancer patients that it is the second hand. Mm-hmm. What I do, and I'm going to give you a personal example, is my dad. Mm-hmm. He lives downtown in the West End. He's very distrusting of medical providers. Mm-hmm. And then you have his daughter that is a medical provider. So one thing that he and I have come up with, he's a heavy smoker. He's been smoking since he's 17 years old. My dad is now 70. Mm-hmm. The reality of him not smoking is slim to none, but I have gotten him to decrease the amount that he smokes. I've gotten him to go outside and smoke. So some of the other things that I like to do as far as the patients, like I said, I can't change the environment at that time. Now, I will be out there community organizing with them and voting and fighting for them. But one of the other things I like to do is talk to them about things that you can get inside your house that is covered by insurance to help you. So that might be a humidifier, right? It might be masks. It might be having someone come and check in to see if there's mold or mildew in the house. So those are some of the realistic things that I can do to help patients and to support them.
Virginia, with the work that you do, particularly in the communities in which you work, there are a couple of things that come to mind if you could address. Number one, though, is it was brought up, this question of mistrust, perhaps. And then two, if you would address, would you dispel or confirm the myth and of the stereotype of patients in lower socioeconomic groups, and in particular African Americans, about not trusting doctors or even not being as caring about their own personal health?
All right, that's two parts. So the first part...
Well, I know you can handle it.
Well, you can help my brain here a little bit. But I think the first part is that there is still mistrust. I still see the need for patients. I still hear from patients that they still need people who look like them to be able to talk about openly and honestly what they're dealing with. They might have cancer, but that's not their top priority on that particular day. That particular day, they might be saying, you know what, I need some help. I need financial help with my rent. Rent is a big issue.
Yeah.
When you can't work, you can't pay your bills. So the mistrust with some providers, that they feel that they're looking down on them. They don't understand that their stress levels are high because they've got a lot of worries. You know, worries that someone else with a higher economic threshold, they don't have a problem with. You know, I can pay my bills. I have money saved that I can live for a year without having to work. But most of our patients that we see, they're not in that category. Secondly, I think that the trust also comes with not being felt that their question is irrelevant. If you have a question and you don't even understand how to present it, that provider needs to take the time to listen instead of talking over them or talking in the language that they can't understand, the words that they can't understand. They need to learn how to come down to that patient's level. And a good example, I'm going to use my mother. The woman who raised me was an older woman. And with her doctor, she'd say, Doc, I got the swimming of the head. But he was a country doctor. You know, he was a boy from the country, and he understood that that meant that she was dizzy. Some people would look at her and think, okay, I think she needs to see a mental health professional, you know, not really understand the culture. So culture is still important. I think now we have more primary care providers that look like us, mental health providers, social workers. And that's not to say that everyone else is not able to connect. But I'm just saying there are people that are still mistrusting of someone who doesn't look like them or understand their needs.
From your experience, I'm sorry.
Can I, on that, and just share a quick experience. 7 years ago or 8 years ago when we started our community health worker program, one of the very first calls we got was from a gentleman, an older gentleman who had diabetes. He was already a one-time amputee. And we actually got a call from his mother who said, you know, I think something's wrong with his other leg, and he's just very depressed, and, you know, I don't know what to do. And our community health worker went out to have a conversation with him and, you know, and discovered from him, well, he was primarily concerned because he had been out of work and he just was really frustrated not being able to work. And that was his chief concern. And so she asked, well, but what about your leg? Like you're having difficulty with your leg. He's like, doesn't matter. I'll just go to the emergency room later this week. They'll probably just amputate it, right? And she asked, she said, that may not be necessary. Why would you do that? Why not go to your doctor? And he said, well, my doctor never listens to me. And he never has, and so he'd probably say the same thing. So why bother and just save myself the trouble? And so she asked the question. She said, "Have you ever had a doctor that you trusted? Anybody?" And so he thought about it, and he said, "You know, actually, the guy who amputated my left foot, I really liked him. He took care with me or whatever." And she said, "Okay, do you remember his name?" She found his name, contacted that doctor, happened to get an appointment with him. Doctor came in and said, "You know, I'm glad you came in because you're right. Had you gone to the ER, they probably would have just amputated it, but that's not necessary. We can save your leg." And he got the care he needed. And the conversation our community health worker had after him, and it's one that we've had with several people since then, has been, I think, also empowering for patients to let them know that you have options, right? Like the doctor you have doesn't have to be the doctor that you have, that just because that is who got assigned to you or that's who showed up that day, if you don't like the care that you are getting, you have every right to go out and seek other care. And I think that's something that we don't say to patients, we don't say to community members far enough, that you have the right to go out and find additional care or care that you feel is best supportive and representative of who you are. And I think sometimes just hearing that, because most people don't know about that or think about that, I think that becomes critically important in how we engage one another and our family members, to tell them, like, you don't like your doctor? Let's find you a new one.
Right. Michelle, we're going to come back to that point in a minute. I want you to talk about what happens if you don't get along with the people. But I want Virginia, if you would make a comment.
Yes.
When it comes to getting screening for lung cancer, who's making that recommendation? Is it the patient telling, hey, I got this and we need to get this? Or are they dependent upon the physician or nurse practitioner, wherever their primary provider is?
I think the patient is dependent on the doctor making the recommendation. But that's from a lack of education about lung cancer screening and how prevalent it is now. Again, it's another cancer that early detection, we may not be able to prevent it, but early detection, you can live. Mm-hmm. And that's one of the messages. What we're doing with the Kentucky Cancer Program and KAC is trying to make sure that our primary care physicians have the tools and the information themselves to feel more comfortable in talking with their patients. Mm-hmm. Because a lot of times it's a check mark on their chart. Yeah, I said something. Do you smoke? And you do. Do you want to quit? And that's the end of it. Not letting them know that there are other resources that can be very beneficial mm-hmm. in getting them to either decrease the amount that they're smoking or working toward that goal of mm-hmm. cessation.
You said KAC. What is that?
Kentucky African Americans Against Cancer.
Okay, thank you very much. Okay, Michelle. So Lyndon gave us a great example of a disconnect between provider and the patient. This is already a stressful thing, and the provider's coming in, I got your diagnosis, this is what I'm going to do. Boom. Does the patient have a choice?
The patient always has a choice, but I'm going to put it back on us healthcare professionals. Is our communication with that patient, are we really giving them a choice? Because it's our we have to have empathetic communication and be for the person in front of us. And so it's not how we talk to, it's not what we say to the person that we're treating, it's how we say it. We know the lung cancer screening rates are low, and we're like, we don't know why. It must be because patients and the community doesn't want it. Well, have we told them? And if we told them, how do we tell them? And how are we communicating to the patient? And so if we're like going, oh yeah, you smoke, you won't stop, then, well, you know what, then they're not going to get screened. Sometimes we have to be reflective on our communication as healthcare professionals and nurse navigators and our implicit bias. People have a lived experience. We have to meet people where they are, and we have to provide support, and we have to not assume that someone doesn't want to quit smoking, because I've been doing this since 2012. I started with the University of Cincinnati, Kentucky, and Georgia, and so every person I have spoken to in lung cancer screening programs have wanted to be screened. They all wanted to quit. Now, some people have had a tougher journey, but we have to be there for the person. They're part of the medical team. If you want, and they are the leaders. They're the expert in their person. Yes, healthcare professionals may be experts in the science of it, but the person is the expert in the person, and their value and input is part of that medical decision making. And so in evidence-based practice, it's not only guidelines, but it's the physician as well as the patient preference. The patient is the center of care, and we need to empower that person in the medical decision making and be there for them and be aware of our communication patterns that we may not be aware of, but we need to be aware of how we're communicating in order to make sure the people are fully informed and making what is best decision possible for themselves.
Lyndon, we're going to start with you. I'm going to ask each one of you to say one thing that you want to make sure that we take home from this. It can be about the navigation, it can be about the support, or it could be even about providing care for a patient. But what it is, that one thing that you think that is tantamount that we take back from this? Lyndon, go ahead, sir.
Just one?
I know.
Let's see if I can roll two into one. So I will talk about the importance of support. I mentioned that I also sit on the board of Gilda's Club of Kentuckiana, a cancer support community, which partners with KAC here locally to support both patients who are going through their cancer journey, but also their families and caregivers. And that is incredibly important, that those who are caring for folks who are dealing with cancer also receive care and support, because the toll that that caregiving takes on individuals is incredibly real and incredibly difficult, and it is very difficult to manage. And so everybody needs support in the process. And so it is helpful to reach out to these different cancer care communities, whether it's Gilda's, whether it's KAC or others, because there is power in being in connection with people who are dealing with this. And here's where I'll roll in my sub-point in that, is because there's also knowledge and information that comes with that as well. Because what you will find is that depending on who your doctor is or where you're receiving care, there may be different resources and opportunities and access to different things that your doctor may not have shared with you. And so sometimes being able to talk to somebody who has a similar diagnosis or who has been through a similar thing to say, oh, okay, what have you done, or where have you gone, or what has happened? They may tell you things that you've never heard of. And that gives you power to go back to your provider to say, hey, what about this particular treatment? What about this particular medication? What about this particular option? Have we talked about that? And then you can have an informed conversation with your provider about your own care, about your family members' care. And so these networks of support are critical, not just for the spiritual and mental and emotional, but actually for the medical benefits as well. Like, they can do a lot to help you. And so support communities, I think, are incredibly important.
Thank you very much. Michelle?
Oh, so
You get one.
I think I get one. I agree with him in terms of support communities. Trying to connect with the support communities. I know with the lung cancer communities, we're all tight. So we have the Gilda's Club Cancer Support Community. Go To for Lung Cancer has a helpline, and it's answered by, like, I think 3 people, but they will get back with you any part. So even if you're trying to get screened, or you're having symptoms, or you've just been diagnosed, or you can't, or biomarker testing, if you're having problems getting biomarker testing, which is standard of care, contact them. We can connect you to resources in the community. Same thing with longevity. We have a helpline that we can get to you. We can connect you with every single one of these organizations, from the KCP, everyone. They're all connected. We will get the resources. Don't worry about the financial. We will deal with that for you, and we will find those resources. But we can also connect you with caregivers and other survivors with your exact cancer type. We can, and to communicate, to guide you through the process.
Thank you. Yolanda?
I wish I had went first, because I feel like they took all my answers.
They did take a lot. That was good stuff.
Here's what I'm going to say. He said support. She said support and resources. I'm going to say what I am, which is a resource. Resource is not just one particular thing. It's financial, it's insurance, it's education, and it's help with the mental aspect of lung cancer, because that's a truly, lung cancer is broad. Patients' needs are broad, just so they know that their needs can be met in the community. So again, I'm piggyback on resources, but I'm expanding that. And also patients having an advocate is important. They know who to go to. They know who they're comfortable going to.
Thank you. Virginia, you get the last word.
I know, and everyone had something very valuable to say. It is about the support. It is about finding resources. And having been a nurse as long as I've been, it's been detrimental to not know what resources our community has. Sometimes it's difficult to locate what specifically we need, but that's why it's good for us to be able to communicate with each other around this county and just knowing what we do have. So the Pathfinder is one tool that we use that, you know, lists all of those things that we've talked about and where you can at least start that conversation. The other thing that I think education is the key. You know, our people will perish due to a lack of knowledge. And the more that you can know, the more questions you ask, the better your care is going to be, the better the navigator, the social worker, the nurse, the team can be able to facilitate and care for that patient and the family as a whole.
Well, thank you very much to the entire panel. I think you've given us some really, really wonderful information and raised some points that I think we all need to act upon. Again, I want to thank you. It's been a wonderful experience. I learned a lot, and I hope that the rest of you also have gotten something out of this. Thank you, panel. Thank you very much. You can go. You are released. On with the second part. By the way, okay. We're going to move on to the second part of our program today. That's going to be on diversity in clinical trial participation. The speaker is me. I am Wayne Tuxton. I'm a colon rectal surgeon by training, interested more in healthcare disparities and what we can do as far as African Americans, particularly as it relates to cancer. I'm going to give a little presentation about cancer, what's going on as far as clinical trials and some of the things that we can do to try to improve ourselves. If I can get the first slide, please. Give me a moment while I get that set up. Great, great. We can go to the second slide. Thank you very much. You know, when we're talking about lung cancer, we all know what the problem is. There's almost going to be 240,000 new cases this year alone, of which more are going to be in men than are going to be in women. Surprisingly, though most of us tend to think about lung cancer in young people, it's actually a disease of the older folks, mainly over the age of 65. It is such a prevalent problem that 1 in 5 of all cancers that take place are lung cancer. And in fact, it is more common than colon, breast, and prostate cancer put together. Now, African American men are 12% more likely to develop lung cancer than are white men. But interestingly, in the case of women, black women are about 16% lower incidence or chances of dying than white women. Next slide, please. As I said, it is the #1 cause of death due to cancer in the United States. And as I said, but it's more common than breast, prostate, colon, rectal things put together. Next slide, please. Now, this is going to be a little difficult to see, but the main point is that in cases of lung cancer, black folks die at higher rates than whites. And this is going to be even when we look as far as therapy that patients will receive. Next slide, please. When we look at the relative 5-year survival rate, what that means is how many people are actually living per 100,000, per percentage of patients that have a particular disease. The good news on lung cancer is that it's actually getting better overall for the entire population. If we go back as far as 1995, there was a 14% 5-year survival rate. In other words, if you were diagnosed as having lung cancer in 1995, there was only a 14% chance that you were going to live 5 years. That's pretty dismal. You go fast forward to 2000, it increased very little, 15. In 2010, there was a slightly increased rate up to 19, almost 20. But by the time you get to now, in 2019, really, this is the last time we have 5-year survival data, the number or the percentage of a chance of a person surviving is up to 28%. And that's a huge jump in the course of 20 years. Just think about it. From 14 to 28, we have doubled the survival for patients with lung cancer. And that is something that is fairly impressive. But the question is this across all populations? Next slide, please. The reason why it is anticipated that the death rate from lung cancer has gone down, number one, fewer people are smoking now. Some of the commercials that we're seeing, some of the black box warning that we're seeing on the cigarettes are having some impact. We know also that more people are quitting. As we had from our panel just now, we talked about there are ways and support groups as far as helping people to quit smoking. So again, fewer people smoking, more people stopping after they started. But we've also gotten better as far as making the diagnosis of cancer, and the treatment of lung cancer, like all cancers, has improved significantly. Another factor, and we'll talk a little bit about this in a little bit, is patients' general health. Many people are healthier, therefore they can tolerate the treatment of the disease, therefore increasing the 5-year survival rates. And the effectiveness of treatment plans. We are getting better at using specific treatment directed at a patient for their particular problem. Rather than coming at things with a sledgehammer, we can be more, part of the term, surgical and be more precise in how we're managing these patients. But the biggest reason has to be the stage at which we're diagnosing the cancer. Next slide, please. Now, when we're talking about stage means how far along has the cancer progressed. So the American Cancer Society tends to break it down and make it easy for us and say early, late, and then early, middle, and then distant disease. Early just means the cancer is confined to the lung itself. Middle stage there, or distant, is going to be in the area surrounding it, and metastatic is going to be it's gone to other areas of the body. So if you can catch something early, you can cure a person of their disease. This works for cancer, this works for infections, this works for many things. And that's going to be the biggest take-home I hope from this, is that if you can make the diagnosis early, and we can do this with screening, this is the number one driver of improving overall 5-year survival rates. Now, what are the recommendations as far as screening for lung cancer? Back prior to 2001, the recommendation was getting lung cancer screening starting at age 55 up to 71. You have to be asymptomatic. Screening, by definition, is looking for a common disease in the population that you have something you can treat with, and then doing it. If you're symptomatic, person's coughing or can't breathe or COPD, that's no longer an asymptomatic individual, and doing any workup is not screening. Screening is you have to be asymptomatic and you have something that we can do something about. You also had to have a 30-pack year history of smoking back in. And what a pack year means, if you're smoking 1 pack a day for X number of years, that's going to be a pack year. And you have to be either a current smoker or someone who quit within the past 15 years. This was the recommendation prior to 21. And the reason why this has changed is we found that with African Americans, we tended to smoke, we have a 20-pack year history of cigarette smoking, not the 30. And we also were having disease just a little bit early. So because of this, and when we go back and looking at the statistics as far as how the disease was playing out and who we were and were not getting with our screening programs, the United States Public Health, the United States Preventative Services and Task Force on Lung Cancer Screening Guidelines made the adjustment in 2021. The benefit of that change being made, instead of 55 as the earliest age, dropping it down to 50, and instead of being 30-pack year cigarette smoking, dropping it down to 20, we increased the number of early cancers that were identified in the African American population, in other populations too, but in particular in the African American population, because we lowered the threshold in which we need to start screening people. Next slide, please. Now, overall, for patients who have localized, again, I talked about the different ways the American Cancer Society classifies things. Localized, regional, and then distant. Localized, again, meaning confined to the lung itself. If you get identified with disease confined to the lung, there is a greater than a 60% chance of your being cured of your disease. Now just think about that. If it's confined to the lung itself, a small little area in the lung, you have a better than 60% chance of being cured. If it's distant, if it's already outside the confines of the lung, into other parts of the body, it drops down to under 10%. So again, catch it early, improve chance of survival. Overall, as I said before, the chances of 5-year survival for lung cancer is about 28%. But you can push yourself up to a better chance of being cured with earlier diagnosis of the disease. Next slide, please. Now, we talked a little bit about in that last panel about some of the things that people do, but there was one thing that touched on just briefly there was about clinical trials. When we look at clinical trials as far as lung cancer is concerned, we find out that about 79%, almost 80% of the enrollees in these trials were white, and 15% were black. Now, it has oftentimes been assumed that African Americans don't participate in clinical trials, and to some degree, that is correct. But on the other hand, if you look at 2020 census data, 15% is about the number of which African Americans are in the population. So we're pretty much, representative in terms of the oncology trials. But it's not consistent across all cancers. For instance, in breast cancer, only about 12% of the patients who enrolled in clinical trials were African American. And it comes down to lung cancer, only 8%. Now, I already talked about how the difference between white patients and black, we found that African American patients, even when they're smoking about 20 packs per day, had an increased risk for developing cancer compared to the 30 as far as the white population. So we need to look in trials as far as to find out what are the differences and how people are responding. So also what we looked at is when you look at clinical trials, how is this distributed about through various areas? 70% of the African Americans who participate in any trials on lung cancer come from just 10% of the sites that are being used. So it would almost be like me to take a handful and take the people that are in this room, and I would say, okay, this is a representative sample of everybody in the country. That's absurd. You have to go to different places and get a sample. Otherwise, we have a sample bias when we're not getting the full picture about how people will respond and do with various drug treatments, surgical treatments, and understand the basic behavior of the disease. So we're doing something wrong here. Next slide, please. What is it that we're doing wrong when it comes down to clinical trials? Well, it comes down to a question of mistrust. And there are two types of mistrust, cultural and medical mistrust. Cultural is the tendency to distrust whites based upon a legacy of direct or vicarious exposure to racism or unfair treatment by whites. I think all of us can relate to that. Either we have had some exposure, or a family member or somebody we know or something in our neighborhood that makes us less trusting. Think about the officer who stopped a young man who was 17 years old who went to get a Slurpee, and the cop pulls him over, handcuffs him, puts him on the side of the road, and then after he's finished, when they say, okay, well, there's nothing wrong here, and they ask, how come you black people don't trust us? Well, clearly, there's a cultural mistrust here based upon our experience with individuals in authority. Medical mistrust, on the other hand, is the tendency to distrust medical systems and personnel believed to represent the dominant culture. Next slide, please. A good example of the cultural mistrust is the Henrietta Lacks. I don't know how many of you are familiar. I'm sure most of you are. Henrietta Lacks, African-American female in Baltimore, Maryland, who had a cervical cancer. During the course of her treatment, as was pretty much a routine, samples of cells of hers were taken, sent to the pathologist for evaluation to confirm the diagnosis. Well, what they did was they kept those cells. And at the time, we were trying to develop cell cultures, a group of cells that would grow so you can test. It had been an abysmal failure. They weren't able to do so until Miss Lacks cells. For some reason or another, they could grow in a cell culture better than anything anyone had ever seen before. And they were able to take these cells and culture them, and they had a whole cell line, which they then referred to as the HeLa, Henrietta Lacks, H-E-L-A, Henrietta Lacks. And these cells are in use to this day. Many drugs that are tried at cellular level are still used by this. Industry uses this. Billions and billions of dollars have been generated based upon Ms. Lacks' cells. There's a problem. Number one, nobody ever asked her if it's okay to use her cells. And number two, none of that money has been distributed to any of the family members. No compensation today. Even though Johns Hopkins just a couple of years ago finally admitted that this is what went on and offered an apology. No money, but they did offer an apology, somewhat of an empty gesture. But this is how an African American was figured, hey, what the heck, it's African American, we can just use them as we want to use them. Next slide, please. Perhaps the biggest thing as far as medical mistrust we all hear about is the United States Public Health Service Tuskegee study of untreated syphilis in the Negro male. And if you take nothing away from this discussion that I give you today, never, ever again say the Tuskegee study on syphilis. That's not true. This was a United States Public Health Service study. It was not generated by Tuskegee Institute. It was not generated by anybody at Tuskegee. It was the United States Public Health Service. Let us put blame for this study where blame belongs. So never again just say, oh, the Tuskegee study. No, United States Public Health Service study, Tuskegee study on treated males. So what was happening back when this study was started in 1932? There was really no effective treatment for syphilis. So they decided to see what happens in people and follow them to see what happens if you don't treat them. Well, during the course of this study, penicillin was actually found to be very effective on syphilis. However, it was withheld from these individuals. Now, what is the impact of this study? Well, 128 of the people who were in the study died. But worse, 40 of their wives died and got infected with syphilis, because they were having sex with these men who had syphilis that was untreated. And then 19 children developed congenital syphilis problems. This is a travesty. This is an abomination upon anything that goes as far as medical care. That we withheld treatment and didn't tell the people what was going on. They had no consent, and they weren't involved in making any decision making. As a consequence of this, many of us still harbor questions when we get involved in clinical trials. I can tell you that because of this study and Henrietta Lacks, the rules of engagement have changed dramatically, but unfortunately, we've seen, ask the American Indian as far as what happens when rules of engagement are entered into and how quickly these contracts get broken. There's a level of distrust. Cultural and medical mistrust do conflict with one another, or do coincide with each other sometimes. Next slide, please. Now, what impacts people's participation in a clinical trial? Number one, elements, how the study is designed. Logistical problem. Can I get there in time? I'm involved in a clinical trial, and they're down in Lexington, so I've got to drive to Lexington. Well, it's not a long drive, but it's 90 minutes out of my day, down, and 90 minutes back up again. It'd be better if it was close by. So there's a problem. But I'm lucky. I got a car. Suppose you have to depend upon public transportation. Now, for those of you not well aware of public transportation in our community, it's not very good. And they keep cutting back on it. So it makes it difficult for people to participate. Then there's a question of health literacy. Do people really understand what's going on in the trial? Are they being brought in to be able to be willing participants? And there's socio-cultural factors going on. And then, of course, there's this mistrust of academic and research institutions. I can tell you, if you're an African American in Baltimore, Maryland, one of the last places you ever go to is Johns Hopkins University. Because they say, you go there, they're going to experiment on you. The legacy of Henrietta Lacks is that strong. So there are good reasons why people don't trust or don't get involved in some of these trials. Next slide, please. So how are we going to improve upon that? Well, we got to educate African Americans about the importance of biomedical research. One question you may ask yourself, well, is there really a difference between the way African Americans and whites are going to respond? Well, in some cases, yes. The answer is yes. What's white and what's black, I must admit, is sometimes very difficult to say. We're talking blue-black or someone who's yellow-black. We all know what that means. You got dark-skinned people, you got light-skinned people. Where do you draw the line as far as saying how somebody's going to respond based upon a particular trial? That's why we have to do these things, to find out. We often used to say that, well, men and women responded the same to medications. But using trials, we find out there are differences that we have to make. We also have to address concerns about the clinical trials. Who's looking at the data, who's running the trial itself. We have to have trust with community members. Too often, it's a top-down experience. We're not getting involved at the community level to explain to people what's going on and what importance is going to happen with the information, and then giving them the information back so they can make honest health decisions about themselves. And also, we have to have better communication between healthcare providers. You heard just a few minutes ago about the problems that we run into when physicians or healthcare providers aren't really talking to their patients, the level of concern and confusion that leads to inaction. Next slide, please. When it comes down to talking about treatment for early lung cancer, surgery is the primary modality right now. Things like immunotherapy, chemotherapy, and radiation are reserved for secondary things. When you talk about early lung cancer, and the resections can be just a part of the lung, a whole lobe of a lung, or you're taking out one whole lung called a pneumonectomy. Next slide, please. But the problem is there's a difference in the rate at which African Americans are getting surgery for early lung cancer compared to whites. Oftentimes, it's not being offered to the African American patients compared to white patients. Some of this has to do with a higher rate of refusal by African Americans for having surgery. This is a discussion that we had last week at this very same forum. Some people concern themselves, well, air is going to get to it and it's going to cause it to spread to other parts of the body. I think most of us would see that this is not a true statement, but nonetheless, it's still a belief that we have to work with and come down and explain to the patient that that's not the case. And then it also is noted that even if African Americans receive surgery, they still have overall worse survival rates compared to their white co-patients. Next slide, please. And some of the reason for that is we tend to show up with multiple illnesses at the same time. You may look at some, so I'll take for an example 2 different hospital systems. If you have a hospital system in a big suburban area that's primarily treating patients who are white, who are fairly affluent, they tend to have good overall health. If they're showing up for cancer, it's because they have that cancer. Unfortunately, a lot of times in African American communities and communities of lower socioeconomic status, they tend to come in with multiple or comorbid conditions. In addition to having, in this case, cancer of the lung, they may have a heart condition, they may have kidney disease, they may have diabetes, they may have some obesity. Multiple comorbid conditions adversely impact how well someone's going to do with surgery in terms of how well they can tolerate the surgery and how well they're going to do after the recovery. And many times when we look at people who are dying, we say that they're dying from the cancer itself during that 5 years, but it may be that they're dying because of these other complicating factors as opposed to the cancer itself. And sometimes because of these comorbid conditions, we can't offer the surgery because they'll never tolerate it. They have bad lungs, their heart is so bad, or the kidneys so bad that they can't even tolerate the surgical treatment that we want to do. So they're not going to be considered. Next slide, please. Then also we have the usual social factors that impact healthcare. There's biases, there's access to healthcare, and there's also a question about the quality of care that we receive. And we all know that there's a disparity with all that. Next slide, please. We can improve this by increasing access to a stable and quality healthcare system. We can also look at addressing upstream issues. We can, through nutrition, make people healthier. We can look at the pollution and eliminate that, so that's not compounding the problem. We've got to look at housing. Where are people living? How's that going to impact them? And also transportation. Make it easy for somebody to visit the physician or their health care provider or to get to the hospital. Don't put these things in. Of course, you cannot have any conversation about lung cancer. If you want to talk about the single best way to keep somebody from dying of lung cancer, don't smoke. I started off life in OBGYN before I went into colon and rectal surgery, and I can tell you, I delivered a number of babies, and I don't remember one coming out with a cigarette in his mouth. Not one. It's a learned behavior. We have to, as Yolanda told us a little while ago, we have to meet people where they are and help them come from that. And also we got to do the screening thing. Let's get people screened. Next slide, please. So if we can do these things, we can probably improve upon those survival rates for patients with early stage lung cancer. And we can make them better. We do need to participate in clinical trials because that's the way we get data that tells us how we're going to treat each other. One size does not fit all. But unless we get a good sample of all, we won't know what that size is and what it is that we have to address. And finally, there's this thing, we have to have quality care and we have to be willing to be participants in our own health care and correct those other conditions that complicate our illnesses and make sure that those things are done. With that, I'd like to thank you very much for your attention. If there's any questions, I'd be more than happy to answer them. Otherwise, we will move on with the program. Any questions whatsoever? Well, thank you very much again for participating. We'll next move on to our next policy. Mr. Howard Mosby, who is a CPA and the founding member of the founding board of corporate treasurer of HEAL Collaborative, and he's also a former Georgia State representative. HEAL, of course, is the organization that's putting this program on, and to have the founding member here is quite a wonderful thing. And Mr. Mosby, Representative Mosby, I turn the podium over to you, sir. most of you may not realize the full extent of the, never shake hands with a politician. You never know what you're going to get yourself into. I will now be moderating this panel with Mr. Mosley, who's going to be a member. We have as our panel members Ms. Katera Huron. Boy, I hope and I apologize if I did not get that right. Ms. Huron, as much as I've seen you, I apologize. Thank you, Representative. And secondly, if here, Councilman Ja'Cory Arthur. No, he didn't get to me. Okay, sorry. So this is great. I get to have two of you up here. Now I'm concerned. Now, when we talk about policy, I don't know if how much of you were able to hear from our previous discussion, but you know, we know that, again, we talked about lung cancer and there's a disparity in the disease. There are a number of factors. We talk about higher smoking rates, lack of access, environmental factors. Representative Huron, could you comment, what can you do at the council level, at the city level, to address these factors?
First, thank you all for having me here. I am State Representative Katera Huron, and I represent the 42nd District here in Louisville, which encompasses a big piece of the West End. So I've got Chickasaw, Parkland, California, pretty much everything south of Broadway, and then go into Old Louisville, a little bit by the University of Louisville, and I stretch as far as east as Parkway Village. And so, for one, it's just an honor to be here and an honor to be able to serve. And I will have some full transparency here. Understanding and being engaged with issues as it relates to lung cancer is very new to me. And so as I've sat here, I've had an opportunity to learn some things. But I think that when I look at what is happening in our district, in District 42, there's a couple of things that come to mind. One is the environmental issues that we see in the West End. And then the other issue is the amount of access of how much tobacco and alcohol and those things that are in our neighborhoods. So for example, the other day I was leaving from downtown, and I actually live in Old Louisville, and I was driving, and on one day I wanted a lemon. And so I drove by several corner stores, and I could not find a fresh lemon. From the waterfront to I live like right off of South Floyd Street, and I stopped at all the, little stations, and they had several tobacco options, but not a lemon, and so that was very interesting. And so I think that at the first basis, when we talk about any type of health disparities, we can't talk about it without talking about the environments in which our people are living in, and the fact that we do not have access to whether it is fresh foods, but we have access to all different flavors of tobacco, or that we have little access to health care. So those are some of the things that come to mind to me. And it's so interesting. We're very excited about the Norton Hospital, but it's so disheartening that it has taken that long for us to get services. So when we talk about awareness of lung cancer, I just don't know that it's an issue that is talked about.
Representative Mosley, please.
Yeah, no, she is spot on. I am at a loss. So again, my name is Howard Mosby. I am one of the board members here at Hill. I'm also a former state legislator out of the great state of Georgia. Great state of Atlanta. How about that? Georgia, the rest of it is Mississippi. Let me look at the camera when I say that. No. But no, actually, first of all, as policymakers, and this came from one of my mentors in the policy arena, the only people in the United States of America that make public policy are elected officials. And if you're not engaged with your policymaker, then you're not a part of the process of changing what's happening around you. You can complain with one another. You can talk about how bad this is or how much I am being disparaged here. But if you're not engaging with your policymaker about how do you effectively change policy, then you're not in the game. When they say you're not at the table, you're on the menu. And so what we have to do is make sure that we're continually vigilant about working with our policymakers to address these particular issues that are not equitably being provided to our communities. And it's good to have two policymakers up here, because you get an opportunity now to actually ask your questions, put your hands on individuals that actually are part of the process or know about how the process works.
Representative Herman, unlike Georgia, our legislature, let's put it this way, our governor led the charge as far as expanding Medicaid in order to provide insurance for individuals. As part of that mandate through the Affordable Care Act under Obama, it mandated that there was screening for cancers for everybody. And what our state has been leading the charge as far as making sure these things are all covered free of charge, as it's supposed to be. There was, of course, a judge in Texas who wants to put an end to the mandate for coverage of screening services. He's saying it's an unfunded mandate. He wants to do away with that. How do you, in the state legislature, and I'll ask the same thing, Mr. Mosby, because both of you served under Republican, and this is, I'm not using it in the pejorative sense, but a group who really doesn't want to push that, so that we're continuing access to health services through insurance. What does that battle look like? And how do we try to maintain that which we have?
Yeah, I mean, it's a hard battle. I think that any time that you look at elections, especially statewide elections or national elections, access to health care is one of the biggest issues. And I think that what we have to do and how we have to roll unapologetically is no matter if you're black or white, poor, we need access to health care. And those preventative services is what's going to make sure that our people have the things that they need and are able to live a long-lasting, healthy, and well life. And when you look at, I mean, you talked about it prior to this, all the different misinformation and how black folks have been abused by the medical field. And so it is very imperative that we have those preventative services and access to health care, not only access to health care, but affordable health care. And so that is something that we will continue to battle. That is something right now within the governor election here in Kentucky right now that you hear a lot of folks talking about, that we do have one candidate that doesn't believe that everyone should have access to health care. And you have another candidate that's saying, no, we need to make sure that people have access and we need to expand it. And one of the things that I'm learning as I am newly into this political world and sphere is that, as you said, we have to be at the table. And it's not just us as electeds, but it's also the community. And so there's a lot of things that that folks assume that elected officials know. We're experts in very few things. And there's a lot of other different things that we're not experts in. So we have to hear those stories. We have to know how it is hard for our grandmother, our auntie, or our mother, or our sibling to get the things that they need. Our former Representative Charles Booker, he was able to pass a bill, I believe it was in either 2019 or 2020, that lowered the cost of medication for diabetes, and because he's directly impacted, because he's battling that himself, he was able to advocate and do that. And so, one of the things that I would encourage folks to do is, as you said, is to come and educate us, because we're experts in very few things. And for someone who is a little bit on the younger age, there's a lot of health issues that I'm not aware about, that I don't know about, and so I do lean on other folks for their expertise to help guide me so I can be an advocate and push legislation forward.
So, Representative Mosby, if you would also address that, but in terms of what is the direct impact to certain constituents who tend to be outside of the concerns of the majority parties?
Yeah, and it's an interesting point. We have to deal with the fact that in the political process, it is always about numbers. And don't let Dr. Tuxen fool you, because we had a political conversation today that we should have had that taped. But to have to talk about how policy is made. So in Georgia, the Georgia legislature, the Georgia House of Representatives is made up of 180 members, which means you need 91 people to move a particular piece of legislation. So it's you plus 90 other people have to say, this was a great idea. And as the question came about, most of the individuals in that 180 seat member body they're not also of the same party that I am, and they are not of the same race that I am. And so to get them to agree to a policy position that probably will have in their minds, a minor effect on their community, it's hard to get them on board, number one. Number two, if the policy piece actually could garner wide range support from the population, it will have a direct effect on the ability for that particular party to maintain policy power. And so you'll find policies that are passed that seemingly work against even those populations in order to keep power out of the hands of others who could get it if you were actually. I know we're talking a lot of code up here. Let me be plain. I'm gonna turn this. Let me, because I'm not elected now, so I can say some stuff. Black people don't show up at the legislature. I know Frankfurt is a way, but it is also the place where power is being disseminated in this state. And if you're not there, then you're not part of the equation. When we are in office and we're advocating for our policy positions, we look out in the audience and none of our faces are out there. It's some other folk, and they're looking at us with some level of disdain because we don't like what it is that you're putting forward, and we don't have any of we're not rolling 3, 4, 5 deep in the automobile coming up there to try to advocate for our positions. And so we need to make sure that our people show up at the table. There are a lot of people out there that are interested in ensuring that the issues that affect our community don't see the light of day. Let me just say it plainly. And we have to be vigilant about how we're going to address that and take that power and put it back into our hands and say and our voices need to be heard, and we're coming in mass, and you're not going to be able to do this. If you're going to do this, you're going to do it in my face. It's easy to do it when you're not in the room, but you're going to do this in my face. And the more that we have of that, we can make sure that happens. I know I didn't answer your question, sir, but I wanted to make sure that our people understand and know that it really is about your engagement in this process, number one. Number two, in order to be able to address the fact that individuals whose policy positions are not aligned with ours, that those policy positions actually have a negative effect on other communities that don't look like us. But they are more interested in ensuring that policy power stays in the hands of those individuals instead of ensuring that great health care hits everyone. And it's a conundrum to me, and I don't know how you fix that.
I really want to hear what you would say about that, Representative Huron, because we talked a little bit about medical mistrust, and I'm going to get to a question how that relates, but this sounds more like political mistrust. We don't believe and trust the system.
I mean, it's so true in that, we have to know and understand that we have been left out of the political process for so long. I was elected last year in 2022, and I tell people all the time that if someone would have asked me 5 or 6 years ago if I would have been elected, I would have laughed because I never was engaged politically. And so it wasn't a route that I had personally thought that I would take. And so when you talk about actually once folks are elected and going back and making sure that people know and understand what the process is or just being accessible, it's very difficult. And we have had elected officials come and make promises to our communities, and then once elections are over, they don't see them again till it's a next election time. When I have gone out and knocked on doors, I've heard folks say that they've never had an elected official knock on their door before. And so I do believe that just in general, we have to do a better job of bringing the political process and the policy process to the people and getting folks to understand. And we do it by coming and showing up in places like this. But then we also do it by educating folks and encouraging them. One of the things that I do is encourage, especially our people who are working with young folks, to bring them to my office, to come and see what it looks like, to come and shadow. And I always used to say I don't do politics. And then one person told me, it was an elder, she said to me, "You may not do politics, but politics are doing you." And so that is what we have to make sure that we let people know. But we have been pushed out of the process. We've, historically, I mean, it was only, next year will be 60 years, and I keep saying this to everybody just so everybody understands, but next year is the 60th year anniversary of Freedom Summer. So it was just 60 years ago that you have folks going and making sure that there was a strong number of black young people specifically registered to vote, because for so long they weren't allowing those folks to vote, still weren't allowing those folks to vote. But when you don't allow people to do things and you make it so difficult and hard and it's scary and you're fighting them and you're beating them up, when it's time for them to go vote, they're actually scared to go do it. And I think that historically that's what has happened. And so we have to change that. It's up to us to change that and remind people, not only what our elders have fought for, but now that there are people like us in positions. Right now, we do have a black vice president. Right now, if it was not for the current administration, we wouldn't have Assistant Attorney General Kristen Clark, who has not only been here in Louisville to make sure that justice has been done, but she's been in different places. And so we have to break it down for people and make it make sense for our people and connect the dots. And we have been pushed out of that process, but it is now time for us to take that power back.
Representative Heron, unfortunately, you are tasked with being I'll get just a phone. I get it for you. You are tasked with making medical decisions. Part of the mistrust that many of us may have as constituents of that, we know that black lung disease is still being argued about, and then smoking. Now, one of the things we did here in Kentucky is we raised the tobacco tax, but in the grand scheme of things, it was only raised $1, and there's a lot of pushback from industry about even doing that $1 raising of the tax. How do you navigate commerce and health?
Capitalism is a thing, and unfortunately, it typically is our people who get the short end of the stick on that. And so I do know that there is a tobacco settlement, a work group that continuously meets on a regular basis. I'm not familiar with what happens in that. I probably need to be after sitting here and being a part of this. But we have to push the same way that we push on all issues. And so whether it's the church being involved or folks who are directly impacted or organizations who are doing this work, we need that voice. We have to be educated. Not only us as people that's representing the community, but as you said, the other folks in Frankfurt. For us, we have 100 members, and I will get a little partisan here. There's 20 Democrats and there's 80 Republicans. And so when we talk about if there's anything that we want to get done, whether it's health related, criminal justice related, education related, we're fighting a battle. And one of the main things that we fight right now in Frankfurt is that it's even hard for us to convince our colleagues to even collect data on race-related data, zip code-related data, any type of demographic data on any type of legislation. It's a battle. There was a bill that was passed, I think 2 years ago, that related to substance abuse disorder, and they're going around and doing recovery communities is what they're calling them. And you have to have these certain things in order to become a certified recovery community. And they didn't want demographics a part of that. So if the demographics are not a part of that, then we know that we're going to be left out of that. And so that's one of the biggest fights that we're fighting in Frankfurt, is just saying that we need to collect data on demographics on any type of legislation that has been pushed. And so it sounds like that it would be a low-hanging fruit, but that's our biggest battle, and I think that we have to fight and overcome that first.
Mr. Mosby, along that same lines then, and you can address her, but also if you would include in your response, obviously Georgia, like Kentucky and other states, are being hit with this anything against critical race theory, anything that touches upon, and Representative Heron has already touched upon it a little bit, but how do we introduce the fact that there are disparities, there are reasons why these disparities, and disparities are a consequence of political activity and businesses. How do we push back against that when talking about the health? Again, in lung cancer, we know that African Americans have a poor outcome, but we also tend to live in areas where fewer services and increased risk from outside factors.
No, great question. And you create boogeyman that don't exist. Critical race theory is not a thing that you should fear. It really is about how race has played a role in all aspects of American life, and how those things have affected how we exist today. You can't really talk about domestic violence without talking about how that domestic violence has permeated through that family. It just didn't. It goes from parent to child to so it goes down the line. So, critical race theory actually it's pointing to that. Healthcare exists in that particular same space. I'm going to try to tie these two things together. America is a capitalistic nation. Actually, it's socialistic capitalism, but it's not pure capitalism. But in healthcare, there is not an asset that you own that you're not willing to sacrifice to save your life. Now think about that. And so anything that's put in the way of the profit-making process, i.e. Governmental payers, Medicaid expansion, for instance, socialized medicine, looking at Medicare for all of these different programs are a direct affront to the profit-making motive of a capitalistic organization or society. And healthcare right now is one of those last bastions in this area where industry is trying to make sure it continues to keep its hand on the profit-making machine. Every time that there is a policy issue that comes out that addresses or affects the way profit is being made by these organizations, you get a lot of pushback from one side or another. I'm trying not to make this partisan, but it really is. One side is more focused on this free market piece, and the other side is looking at how much should government play a role. My thought process is that government should always try to make the playing field level. It shouldn't be about me fighting uphill or me running a race on a treadmill while you're on the track. Of course, I'm not going to win. It looks like we're doing the same thing. However, I'm not making progress while you are. And so we really need to think through how policy and how industry can coexist to ensure that communities are not left behind. And you really do have to have a more heavily tilted policy answer than just waiting for the market to say, oh, that is the right thing to do, so we're going to do it. And that's why you have to engage individuals like Representative Herron to ensure that your issues are being heard at the state capitol.
Yep. We'll start with you on this one, Representative Mosby. We had, his name was already brought up, Representative Booker, had a brilliant campaign. And I think he was creating a coalition. And essentially, if I remember correctly, Representative Herron will correct me, his tagline was, from the hood to the holler, or holler to the hood. And he was making the association that we really ain't that different. So when it comes to health care, it was already mentioned that a new facility is being built in the West End, the African-American portion of Louisville, or Jefferson County, I should say, where there was a desert as far as a hospital was concerned. At the same time, we're seeing an unprecedented shutdown of hospitals in rural areas. So with that idea of a coalition where you have people living in hollers who are losing health care and limited access of people in urban centers having limited access, some of it because of insurance or accessibility and other issues. What policy do you do to drive that, to bring these two disparate groups together? You talked a little bit about how the boogeyman is introduced to keep us separate, but how do we actually show people, say, hey, your health problem is this health problem, and we need to work together to make this solution? You start. You started this, sir. Okay. Yeah.
Oh, okay. I'll make sure. First of all, there needs to be an acknowledgement of the fact that we all are all human, and there is, although my Dr. Tucker said earlier about the blue-black versus the yellow-black. I don't know where I am on that spectrum. I know I'm not a paper bag. However, I am human in this space, and I think that we need to, our society needs to embrace the fact that the strength of America exists where we are at our weakest. And if we're not willing collectively to build up the weakest parts of our nation, then we will always be continually weak as a nation. Healthcare is the same thing. We're not going to make progress, real progress in healthcare until we start dealing with those areas that have been disproportionately affected by policy as it relates to the delivery of healthcare. And we need to really think as an industry itself really needs to think about it needs to be more intentional about how we bring those resources to those individuals so that they can actually participate in the thing that we call the American dream. Individuals can have access to great quality of life by the fact that they have great health care. If we can get industry to see everyone the same, if we can get policymakers to see we all are in this fight together, I think we can go a lot further. The problem is our communities are so far behind that the amount of resources that it's going to take a disproportionate amount of resource to get us to be even, that folk don't want to spend dollars out of their pocket that's going to help somebody else without it helping themselves, and not seeing the larger picture of even if you make this investment, and that's what it is, you make this investment, that it actually all boats rise. So let's do that. But getting that message across, getting people to say, I'm willing to make the sacrifice. I'm willing to, or industry, making this sacrifice that we're going to be intentional and we're going to put more resources in this area disproportionately to address the disproportionality.
Yeah, that does, because then Representative Heron, the question becomes, as I said, so you don't have a resource where we can do lung cancer screening because the facility's not there. So if we don't have it in this urban area and you don't have it in this rural area, what is the argument that you make to say we have to put and make sure this facility stays viable so that this resource is going to be there to help decrease, in the case of lung cancer screening, so we have a place where a person can go get a CT scan done so they can get screened for lung cancer and cut costs as far as lung cancer treatment down the road?
I think one of the biggest things that we have to figure out is how do we make it make sense in dollars, and not just dollars on how much it's going to cost to care for folks, but what is it going to cost if we don't care for folks? And as you talk about the disproportionate amount of resources that are needed, when you look at some of these communities, people are, doctors are leaving not only just because of that, but they're leaving also because of some of the policies that are being passed as well. And so when you talk about what the future is for a certain community, whether you're talking about Eastern Kentucky or another area, we have to also figure out what does this mean? How do we invest in this community now to make sure in 20 years that this community is actually a thriving community? Because what you're seeing now, especially here in Kentucky, and I think that other people across the nation has talked about it, is that you have the older folks who are dying off and you have the younger people who are leaving the community and not coming back. And so I think one of the things that we need to do, and I'm not that's not my lane either. But we got to figure out,
going to be though, right?
Yes, it's going to be my lane now, but we got to figure out what is the long-term economic impact on the community, on the people, and on the region if we don't invest in these things right now. And I think that's where, not only on this issue, but on a couple other issues I've been thinking about is how do we talk about this, and if we don't do this now, what is this going to mean in 20 or 30 years? And hopefully that'll shed some light.
And let me just add, she said something that was real key too. There's a certain language now. It's great to see the bombastic nature of how we operate and how sometimes we can be animated in what we do. But in this space here, we really need to be strategic about how do we get our points across. And we really do need to think through how we are messaging what it is that's important to our community. And a lot of times people will just shut off if you come at them a certain way. Mm-hmm. And we really, at the end of the day, it really is not about whether or not, I'm trying to keep my words straight here. It really is about how it's getting the message across, and not about how I'm being seen or lack of disrespect. But it really is about can we work together? Can we get some things done? Can we make this thing move? And anybody that walks through the political process thinking that the minute that I talk to Representative Heron and I give her my issue, that thing is going to be dealt with next week, doesn't understand civics. It is once you decide to engage in the political process, you're in this for the long haul. It could be a year, it could be 10, but you have to be okay with that. And if your thing is that we got to have it now or we're going to blow the system up, then you might as well, instead of having a conversation, you come in with your dynamite, because that's what it'll be.
Representative Mosby, I want you to put on 3 hats for me. Number one, you got to go back as you're in the legislature, mm-hmm. when you're appropriating healthcare dollars. 2, you're a hospital administrator, and you have some familiarity about that. And 3, you're an advocate for health. And by the way, if anyone has any questions, please feel free to raise your hand. I will recognize them. So you're an advocate now for healthcare. We know that using biomarkers We can take the tumor, and we can take pieces of it, and we can determine based upon these biomarkers which form of therapy the person will most likely respond, be it a chemotherapy or even specifically immunotherapy, which allows us therefore to, again, we talked earlier, not hit the patient with a sledgehammer, but be far more precise, like a watchmaker, and just picking out the things. But this stuff costs, and it's but we consider it best practice. Representative Heron talked about, but if we can do something to keep people alive, it's going to save money in the long run. But on the other hand, it's a heck of an expense up front. How do you handle the appropriations for that? Wearing those hats. Which way? I want to hear how you go crazy trying to explain this one for me.
I got 3 or 4 more hats. I'm also a certified public accountant, and I run a nonprofit. So you throw all that in there, and then you try to make this.
You don't have to be a lawyer, too, right?
And then
okay, you're safe then. All right, go ahead, sir.
So let's start with the appropriations process. So looking at biomarkers, again, I talked earlier about how, from a capitalistic standpoint, how lucrative healthcare is. When you look at a bill like biomarker, or you look at a policy like making sure that people have access to biomarker testing, it is it's a multi-visit thing, and it is also very expensive. The issue here is about the word investment. And so we're going to allow for payers to pay for this in the event that we are going to not only save more lives, but we're going to keep more people out of the hospital in the long run. So we're going to make this investment on the front side. So this is where policy then becomes a bifurcated process. So they'll make sure that biomarker testing is available for people who are on private payers, but not the governmental payers, because the government is not going to pay for this. Where this is where your voice, all of you all, are important, where you make sure that the legislature knows that Medicaid and Medicare cannot be left out of the equation. So governmental payers get pay for that, and you do that through investment. As a hospital administrator, you are almost agnostic about who's going to pay for it, as long as it is paid for. But at the end of the day, if your mission is to take care of the least of these, and they walk in the front door and they need this test, do you devote the resources in your organization to actually take care of? Again, this is another question about investment. Do you make the investment in making sure these individuals get actual access to this screening so that you can keep them out of your emergency room, so you can keep them out of long-term care in the hospital? We all know that you get paid on DRGs, and that is developed on a certain number of days that you should be in the hospital. Well, if you don't get the state-of-the-art treatment, from the story from the last panel, you go in there and they cut your leg off. They're going to just lop off half your lung and see what happens after that, instead of ensuring that you get the right test, get the right targeted test, get the right therapy. Also, as I'm trying to figure out what other hat you want me to put on, but as someone who's working in the space as a concerned citizen and the person that wants to bring this kind of education to the community, it just makes complete sense for us to, as a society, to ensure that individuals get access to this type of state-of-the-art treatment. I can eradicate your entire body, or I can hit this one point, or I can give you an oral medication with biomarker testing allows physicians to be able to do is to give you oral medication to actually deal with this particular chemo or this particular mutation in your lungs. Makes a lot more policy sense. It makes a lot more sense around how hospitals should engage in this space. It makes more sense. It makes sense for the family. It makes sense for the patient. Outcomes are better. It's a no-brainer. And as a hospital administrator, it should be a no-brainer to do, whether it's covered or not. Mm-hmm. It should make more sense. And as a policymaker, we should want to make sure that the playing field is level and people have access. Why give people 18th century leeches then? That's what we're going to pay for that.
Representative Hearn, please respond. How would you answer that?
I mean, I think that he's spot on. Like we just have to. It's about that investment. And one of the things that I'm learning as I'm going through this process is that everything that we do, it is about investment, and we have to make sure that our colleagues know that Black people deserve to be invested in, whether it is education, healthcare, whatever the issue is, and we have to demand that. Not only do we have to show up in the political spaces and talk about that, but we also have to make sure that we're working with those other advocacy groups that have the money and the resources that can tap in to make sure that our message and word is getting out.
To that end, Kentucky has a surplus in its fund right now.
They act like they don't. I said they act like they don't.
which is the very point. But there's supposedly, every now and then we hear about this great surplus. Is there any appetite in the legislature for making this investment in, saying, nutritional programs and early educational programs? Because we've demonstrated that these two things will have an impact on illnesses, chronic illnesses down the road, and also whether or not we can do things about cleaning up our environment also will have a tremendous impact on chronic illnesses. And again, as an investment thought, will decrease healthcare costs 20 years down the road. Won't do it in 5 years, make no mistake, but 20 years down the road, we probably have a significant improvement in quality of health, therefore it'll be cheaper.
We have a large amount of surplus right now in Kentucky, and next session in January is a budget year. So right now we are having those budget conversations, and those are very hard conversations. So for folks, as we talk about the political process, we have a chair and a co-chair over the appropriations. And honestly, what I am learning is that if you can convince those two individuals of the request that you have, it might make it a little bit further. But as we talk about that process,
I'm sorry. Could you repeat what you
define? He asked me to define convince. It's a lot of conversations that you're having, and literally, I can talk about this because I've been going through the process for the last couple of months. I've asked for $3 million. That's it, 3. Mm-hmm. That's not a lot of money. I've asked for $3 million to start an office of gun violence prevention at the state level, and the amount of pushback that I'm getting is crazy. And so I say that to say that the process in which to get something in the state budget is a very difficult process. You are going in and you're talking to folks about why that policy issue even matters, and then breaking down of how many people it's going to have an impact on, what's going to be the long-term sustainability, who else supports this, why they should support it. Is really convincing to people that this not only policy issue matters, but the dollar amount matters as well. And so when you're talking about expanding that out to things such as healthcare, again, you can go in and you can talk about the black statistics, but in a majority state they don't care. Right, is probably the easiest way for me to say that. And so it is a lot, and we do have a lot of money. I do have a colleague two colleagues who filed, who are pushing a bill to make a lunch and breakfast free for our students who are in school, and then also there is a push to pay for that early childhood education. And our colleagues are just basically saying no. They do not see value in that. And so as you talked about building those coalitions from the hood to the holler, or what have you, is that we have to make sure that we're not only talking to each other in our community, but we have to figure out who are those other people doing the same work across the state, who care about these issues, who are impacted, and we have to build I believe, a multicultural and a multi-generational coalition in order for us to really get the things done that we need.
Well, before I get to the last question, which will be for you both to answer, what can politics do, or what can you see happening at the state legislature level do to increase the screening and decrease the mortality rate from lung cancer, and how you see that working? As you're thinking about, I'll give you a moment to think about that. I want to take the opportunity to thank the good people at St. Stephen's Baptist Church for having us here, and particularly Reverend Cosby for opening up the church to the resources so that we can have what I find have been a really interesting 3 panels. Well, I should say 2, excluding the one that I was a major part of. That one was less interesting to me. But the ones on either side I thought have been just really, really interesting. We're going to start off with Representative Mosby. Mm-hmm. So as we look at this, and the question is, what can politics or the legislature bring to bear on this subject?
So, great question. I know in the state of Kentucky, and I know Representative Herring can talk about it, House Bill 180, where biomarker testing was passed to ensure that this is now given access of this state-of-the-art treatment for lung cancer. I do believe that things like you talked about the cigarette tax on the front side, where that would help curtail the amount of number of people from smoking, but at the same time, you need to be able to have people have access to primary care physicians so that they can actually get screened. The biggest barrier to screening is your primary care physician actually referring you to a specialist to get that screening. Having that voice, making sure that those positions are funded, making sure that we have enough in this state is extremely important. Also, making sure that these screenings are available to the community. So to say that you can get this lung cancer screening and it's only held over in Bug Tussle doesn't help most of the other people, or it's not available in your community. So making sure that as a policymaker that not only is the screening available, but you also have access to it from a transportation standpoint and the ability to get access to the subject matter experts to do this. Shut up.
Yeah, I think the only thing that I would add to is making sure that we have some research, a policy that's put into place. I think that one of the things that if we don't see the numbers, then it's not happening. And I know that last 2 sessions ago, I believe it was, Senate Bill 276 was passed, and it was dealing with sickle cell. And basically what that said and stated was that there would be an annual report done based on the number of individuals who were coming in and getting access and getting services for sickle cell, and also keeping up with the medications to make sure that the treatments they are getting are sufficient. So I believe that we can do something very similar as it relates to lung cancer or any other disease for that matter, is making sure that we have those policies into place to make sure that our cabinet at the state level is very aware and has their fingers and pulse on it at all times.
Well, I'd like to again thank both of you for your frank, honest, concise, and most instructional answers. It's been really interesting. To bring things to a close, I'm going to have, you want me to continue that? You want
you want me to close it out?
Yes, sir.
Well, can I just say, I had the opportunity to testify in front of the FDA this particular past week about a particular lung cancer medicine that was supposed to be approved. Actually, it's on the market now, and they want to make sure that it continues its process through getting approved, and it was denied by the FDA. In going through that process, it is extremely political, and it's one of these things where our community cannot get access to something because of some bureaucrat or some policymaker somewhere making decisions and not taking into account what's happening in our community. You see CBS right now having health care and Walgreens, and don't be fooled by these docs in the boxes and things of that nature, that you're getting access to the same level of health care that you get in the community. Now, I will admit that something is better than nothing. However, they can do a lot more, and it's not about CBS. This is about how money is being siphoned out of your pocket and being put into a place to do this health care. These things are called PBMs, or pharmacy benefit managers. You got to watch out for that. But policy is this one things that I want all of y'all to understand and walk away from here, that you need to lock arms with your representative here and say, we're going to make change, and this is how you make change. And I'm telling you right now, you do it, it'll be probably one of the best experiences in your life.
And don't forget that there are companies such as CVS where we already have a limited access to pharmacies in certain neighborhoods are closing more down. Mm-hmm. So your admonition that we need to lock arms and support people like Representative Huron is very, very clear. Thank you very much. I think again, I want to thank everyone who's been listening and participating in this. I did not mention at the beginning about an evaluation form that was present. However, I'll take this opportunity to now. There's an evaluation form. And if you have not filled it out, please avail yourself of this opportunity to fill it out, both the pre and now post, so that we can have a better way to track how things are going with this program. So I really would appreciate if you could fill out the evaluation form and make it available for us. At this point, I'd like to invite Ms. Whitson, who's part of the Emergency Medical Response and Health Promotion Ministry here at St. Stephen's Baptist Church, to close us out with a prayer.
Good afternoon. Thanks for everyone that came out. God had his way today. I am with the Emergency Medical Response and Health Promotion Ministry here at St. Stephen Church. And a little bit about what we do. We respond to emergencies that occur here on campus. And then our most challenging task is health promotion. You can join if you're interested in joining. We have a table set up out in the concourse. You can respond to emergencies here at St. Stephen, or you can be part of health promotion. It warmed my heart today to hear some of the buzzwords, and Christine, Mary, Trudy, Kim, you all know the words that I'm talking about. Proactive rather than reactive, positive outcomes, access, and my favorite, collaboration. And I could go on and on. But we truly have our work cut out for us. Survey's been mentioned. Thanks. If we could just bow our heads for a word of prayer. Father God, we thank you. We thank you for this day, a day we've not seen before. We know that you had your way. Things were said and done that we pray will help someone's quality of life. Father, we ask that you bless the food that we're about to receive, and we ask these things in your name. Amen.
And that will conclude our program for today. Thank you for all of you in attendance and those of you online. I hope we all got something out of this. Thank you.